Welcome to the Ortho Joe Podcast, a joint production of the Journal of Bone and Joint Surgery and Ortho Evidence. Join hosts Mohit Bhandari and Marc Swankowski as they discuss current topics and publications in the world of orthopedics and beyond.
Good morning, Mo.
Good morning, Marc. Good morning. You know what?
My Ortho Joe. I saw that earlier before we went live.
You did see, right? Yes, you did see.
I hope the trustees are not watching these and have found that you're.
But I always keep my cup with me. I do have it. It's always there. But you know, in the rush of getting coffee, I just had to do it. But anyways,
yeah.
Tim
Hortons is great, mind you. I'm not disputing that Tim Hortons is an issue. It's the housing of the Tim Hortons.
Housing. That's right. Right. I don't know. I mean, we have two guests here who will definitely, I'm sure, at some point towards the end of this conversation, shed light. But these cups stay warm for a long time. I don't know what they do, but these cups are really good that way.
Not as good as the Ortho Joe mug, which our guests will receive for participating in this podcast.
Right.
So I'd like to, if I could, Marc, welcome two of our guests this morning to talk about an important paper, a paper that was the lead article in this month's Journal of Bone and Joint Surgery. The paper itself was titled Association Between Periprosthetic Joint Infection and Mortality Following Primary Joint Arthroplasty, a very large population-based cohort study conducted in Canada and by two of our investigators. So the lead author for the paper, Raman Mundi, an assistant professor at the University of Toronto, an orthopedic surgeon. And the senior author of the paper was Bheeshma Ravi, who's an associate professor as well, and an orthopedic surgeon practicing at the University of Toronto. Welcome, gentlemen.
Mm-hmm. Thank you for having us.
Can I just ask up front the origins? How did you come up with this idea, or what were the, circumstances that led you to want to explore this particular question?
Yeah, I can start. So once again, thanks, Mo. Thanks, Marc. Thanks for having us and giving us a chance to sort of discuss and highlight this paper. You know, I think we can all agree that prosthetic joint infections are one of the most unfortunate and devastating, if not the most devastating complication associated with joint replacement surgery. And I think it's been well proven that even if you achieve cure, that there's often sort of this chronic morbidity and functional decline that patients have after a prosthetic joint infection. But there's sort of growing evidence that maybe it's just not about morbidity, that it directly increases mortality risk as well. And we came across a few studies. There's some sort of hospital level single center studies, but more recently some evidence from Europe, the Danish hip registry and the Swedish hip registry, which showed that maybe there is a direct increased risk of mortality. And you know, those studies did have some limitations, like they included hip fracture patients, which we know inherently, even without infection, have about a 20 to 30% mortality rate in 1 year. So, you know, we thought that this sort of a good start, but we needed some more definitive evidence with a more robust sort of controlling for confounders. Because if we could show that there is, in fact, a definitive sort of link between infection, prosthetic joint, and mortality, that would have sort of significant implications both clinically and from a research perspective.
Yes, yeah. From your perspective, then, what was the key finding, the message you want readers to take away?
I can speak to that, Raman, if that's okay. So I think our key finding is that although infection is rare after joint replacement, it is potentially has long-term effects. And although we didn't get into it in this study, I think we're going to build on it in future work. But if someone, God forbid, does get an infection, it's imperative that it's treated effectively and likely also treated quickly. So I think every surgeon can speak to having a patient where you're not sure if there's an infection, and in retrospect, you wonder if maybe the workup could have been done a bit faster, et cetera. So I think our work just suggests that if there is suspicion for infection, it needs to be worked up very aggressively and managed, aggressively as well, so that hopefully it's just one more treatment and then the patient is cured. And as opposed to letting it drag out and become a chronic issue that can then have an impact on a patient's lifespan.
And just for clarity, we're talking about a study which included over 175,000 participants. It was an observational study here. And you were looking specifically at patients who came in with an infection within that first year period. So if they get an infection within the first year after a total joint replacement, am I correct to suggest that there's a 5-fold increase in mortality risk over a 10-year period?
Yes, that is what we found. And Obviously, there's an element of residual confounding because sicker patients with comorbidities tend to get infections, and those are also the people that in general would have a higher mortality. We tried matching for that, but even after that, I think it's fair to say there's always an element. You're limited with the cohort study retrospective, but with a 5-fold effect, even if say 2-fold was dismissed because of residual confounding, still a large amount, but there's still an effect size and a signal there that suggests that infection by itself does increase mortality in the long term.
So if I could ask you to, what are the statistical approaches to do your very best to try to limit the confounding with the medical comorbidities? Just maybe educate our listeners a bit on that.
Sure. Raman, I can start if that's okay with you.
No problem.
So it's very challenging to control, obviously, for this. And I think it starts with having accurate data. So if you have a data resource that's been well validated and lists comorbidities, then you could potentially either match for them. And I think right now a lot of people try matching or propensity score matching, or probably stronger is some sort of regression analysis where you sort of control for these. Matching is sometimes, I like matching because I'm simpler. And I think when you match and you can say these patients were matched for this and this, then the answer makes a bit more sense. But a regression is probably more powerful. But I think the more fundamental issue, though, is that the data you have needs to be accurate. So I think in this age of large database studies, we tend to take what's given at face value. So they say hypertension, but we don't know if that hypertension was uncontrolled or controlled, et cetera, et cetera. So having a validated definition is probably the greatest strength. And that's one of the advantages we have here. We use these databases in Ontario, Canada, that are really well validated because people have gone back and done chart reviews. So they've actually said, if it lists hypertension, this is the amount of hypertension this person had. So it gave us a lot more freedom than, say, NISQIP or something else, which is still very powerful. But here, a lot of the definitions are a bit better validated, allowing for better control.
And Bheeshma, and I guess the same to you, Raman, here's, I mean, this particular question really, there is no randomized trial you would ever conduct. It just, there wouldn't be a study. This study question is really to be answered with a large observational cohort study. So, but let me ask you this. If you were to think about a trial, not for this specific question, but let's say it was someone who gets an infection, aggressive treatment or treatment modalities and potential mortality risk. Is that even feasible? I mean, given the fact that it's a couple of 100,000 patients here, will we ever see a trial done in this area with mortality as the outcome?
With mortality as the outcome. I think there's certainly an opportunity to do trials in this sort of area. Sort of two broad categories. One is sort of prevention of infections, and then I think the other sort of category would be sort of our treatment strategies in terms of how we manage these infected patients. Namely antibiotic duration, perioperative strategies, single versus two-stage revisions. That's kind of a big question that remains looming, and I know there is some trials work going on in that. I think you can assess mortality through the trials, but I think it'd be very hard to do as the primary outcome. As you can sort of see, when you have to follow patients out for 5-10 years, clinical trials become, I wouldn't say impractical, but they become subject to a lot of sort of loss to follow-up and challenges. So I think you can assess those things, but I don't think these clinical trials necessarily would be powered with mortality as being the primary outcome.
And do either of you have a sense of, with mortality? So a patient comes in, they get an infection, and then at some period in the next 5 years, they die. Is there a mechanism by which it's happening? Was there a particular type, like mortality encompasses a composite of many ways in which someone can pass? Was there any signal on that, or do you have any exploration of or ideas of why that might be, what might be causing it?
We didn't explore that in great detail, but we do know these were mainly in-hospital deaths, and not to say from a car accident or something else. And one of our sub-analyses, which we didn't include in the final submission, but suggested that in terms of the comorbidities that were the biggest predictors, and also suggested in-hospital death, were things like liver dysfunction and renal dysfunction, which predisposed to an infection, but also predisposed to that infection having an effect on mortality in the long run.
Excellent.
Yeah, I'm going to diverge a little bit from your data to just speak to you as clinicians working in this area. So I think most of the people listening to this are aware of the issue of colonization versus infection, and the studies that have shown that, with retrieval of implants, that a large number of them you can identify bacteria, et cetera. And the whole question of when does colonization become an infection? Do you think that the real issue here, given the fact that a fair number of prostheses have some glycocalyx protected sequestered bacteria, that it's the immune response of the individual that allows a colonization to become an infection? Therefore, the comorbidity is really the most important thing. I'm spouting out a little bit of my own bias on this, but I just wonder if you two think that this is crazy or what's real, what's going on.
I don't think it's crazy at all. I think obviously individuals' health and their overall nutritional status, how they take care of themselves, etc., modulates their immune response and modulates their effect or their response to our treatments. Joint replacement, fracture, anything really. It's a large part is dictated by the patient factors that we can't control. But it goes back to, as surgeons, then we need to modify the things that we can control. We can't really control these patient factors, but we can control potentially other factors in terms of steps we can take to minimize infection. And God forbid if an infection does happen, to then manage it. But I think you're definitely onto something, and that's likely the future of our field, or one component of it, which is improving patient nutrition and other patient factors that may mitigate these outcomes.
Marc, I agree as well. Like, if you look at sort of studies that have, even randomized control trials that have sometimes looked at sort of wound swabs as a kind of as a surrogate for infection, just because it's easier data to collect. There's a large number of patients that end up having positive sort of cultures from these wound swabs at the end of the surgery. And that's without sort of any sort of intraoperative contamination event. And so I do think, it's almost impossible to completely eliminate patients from having any sort of intraoperative bacterial growth into the wound. So I think these sort of patient factors that compromise immune status and predispose them to sort of developing a full sort of prosthetic joint infection are sort of possible important targets, as Bheeshma has suggested.
It's always a good day when an old investigator gets some reinforcement from young active investigators. And this really does fit into the whole wave of microbiome research that is across all surgical fields. So thanks for the reinforcement. Made my day.
So on that topic,
someone's called me young in a while, so that's good.
What's next, gentlemen? What is next for you in this, in this program of research? Are you exploring more? And what can we at the Journal of Bone and Joint Surgery anxiously await as the next contribution to the literature?
I mean, Raman and I have thought about this a great deal, because when we first saw the effect and we thought back on, obviously as every surgeon has a patient that gets infected, we became profoundly depressed as we sort of think, dear God, have I contributed to this patient's long-term mortality? And I think what has assuaged us somewhat is a lot of our work so far has sort of demonstrated the importance of volume, so surgeon volume, on lowering the risk for complications. The more you do something, and the more reflective you are on your outcomes, the more likely you are to reduce complications. And our own feeling is that, and we're currently working on this, is looking at that effect on revisions. There's been so much work on primaries, and we also think that the next part of this will be on these patients that do get an infection. Is there a role for involving even higher level subspecialty, maybe a surgeon that specializes in infections, or a surgeon that has really a good track record of dealing with infections to help you with that procedure? Does that have an effect? Because it may be that infections do happen and they're rare, but perhaps the next step is showing that really effective treatment early on is what can halt the mortality effect. So that's sort of a long-winded explanation of what we're looking at next. Raman, did I miss anything?
No, I don't think so. If I can just quickly, add to that, I kind of look at this as two broad sort of, I mentioned it before, is prevention and treatment. And, I think sort of prevention is always, ideal. And, I think that sometimes we think that with the so-called 0.5 or 1% infection risk, prosthetic joint infection, some people say, well, just by random chance alone, that can't get any better. But what we have to remember is not all arthroplasty patients have an equal risk. I think we've gotten into sort of an era where we're more inclusive in terms of the patients we're operating on. There's kind of getting away with BMI cutoffs, younger patients with more comorbidities, and certain subgroups of patients have higher risks of infection, whether it be sort of 3%, 4%, 5%. And I think those are the patients where we have to say, like, what strategies can we use to prevent infection in these patients? And, if you sort of search of the clinicaltrials.gov, and in Canada alone, just in Ontario and Quebec, there's 4 active clinical trials that are multi-centered looking at sort of infection prevention in arthroplasty patients. So I think that just speaks to sort of, this is not something that's new. It's not novel. It's not robotics. This is sort of, infections have been there since we started doing joint replacements, and yet there's still sort of this ongoing interest to improve infection rates. And then the second category is treatment. I kind of compare this to hip fractures. We know that treatment makes a difference in mortality risk. Timing of surgery makes a difference. There may be something left to uncover here in terms of improving mortality risk, whether, there's some evidence that maybe single stage actually decreases mortality risk compared to 2-stage revisions, suggesting that everyone start doing single stage revisions. It's just early observational data, but I think we need to build on those things. And as Dr. Ravi said, maybe timing to surgery, ability to diagnose these patients quicker and get them cured faster, can make this less of a chronic disease and really influence mortality rates. So I think sort of 2 broad categories is what sort of we need to prioritize.
Yeah, I mean, I would just simply add that, keep at it, because it's the argument, for, it's a relatively rare outcome and therefore we're not likely to move the dial is, well, if they use the same mindset in MIs, which are, 1 to 1.5% mortality, they've got that down to 0.75, 0.3, whatever. And that's been through absolute large teams working together and, coming together globally with a question that matters to everyone, right? When you have an outcome like infection or mortality that matters, you'll have everyone listening, whether they're here in Africa, in India, China, throughout Europe or North America. So congratulations to both of you for continuing this work. And, we wish you all the best as you move forward. And we look forward again to learning more and continuing to, see the work that's coming up from your group. Thank you so much. And I hope you have a good rest of your day.
Thank you, Mel. Thank you, Marc.
Yeah, you're welcome.